Then it's my pleasure to introduce to you the next speaker, Dr. Friedrich from McGill University, who will report about rapid cardiac MRI exams.
Thank you very much. It's a pleasure to be here. After these beautiful images you saw, beautiful from a technical standpoint, just to manage your expectations, I will not come up with very fancy new compressed sensing protocols or machine learning or 3D data acquisition, but with a fairly simple message. What do we do in a department that wants to work in a cost-efficient manner, still provide the best service? And we know one of the roadblocks of CMR in clinical application has been the opportunities we have with CMR, these rich range of methods we can apply that have also been a curse to us, because for many the impression was, yeah, CMR is this technology where you can basically do everything you want, but you need a lot of training, your tech has to be a specialist, and you have to have an expensive machine. It takes an hour or two for the patient to get done. Then you have a slew of images and data, and to deal with that is also difficult. You need specialized software. We have to at some point get to a point where you think about, okay, how can we cater to a private practice, to small hospitals that need a sufficient and efficient MR department that can perform cardiac applications. Now, I'm involved in software development, and I get research support from several sites, and also have a research agreement with GE, just to disclose that. In general, we have to say the direction for cardiac imaging should go from invasive methods that use radiation, contrast agents, and surrogate markers to techniques that do not necessarily use that. And while we do not have a perfect perfect imaging tool that can do all, we should try that with what we're doing, we're accurate and precise, that we have a prognostic value, that we are fast and cost efficient, and eventually improve outcome. Because the most beautiful images do not help if they eventually do not make lives better. And that's always important to keep in mind. And believe it or not, some of this information is not even available for techniques that have been around for 20 years and are a source of making a lot of money, especially in North America. So that's the general direction. And as I said, none of the techniques is perfect. But if there's one technique who's coming pretty close to all that, then it's MR, because it doesn't require radiation. It is safe. And it's pretty good at morphology, although not as good as CT, that has a high spatial resolution. It's the gold standard for function and for tissue. And for metabolic applications, yes, there are more specific markers used in nuclear medicine, but MR has also very good options. In fact, I sometimes say that MR can only do metabolic imaging, because what we see, the signal depends on the metabolic environment of the spins we're playing with. And we all know that MR has a lot of options to assess the heart with respect to function, morphology, flow, perfusion, and all that. But of course, the question is, what exactly do we need? And of course, we cannot do the idea of a one-stop shop floated around 20 years ago. We say, okay, let's do a scan where you do everything, and then you take your patient out, and then you figure out what you want to see. And that didn't make sense. That still doesn't make sense. Actually, it may make sense in the future. Techniques like multitasking may allow us in the future to acquire 3 data set, and then later on indeed to decide what we want to look at. But at this time, we're not there yet. So it is important to focus. And that's what I tell everybody who gets started with a cardiac MR service. Focus initially on the important indications. Now, why is that especially important? We cannot afford a healthcare where we apply an expensive imaging technique to everybody. And in North America, but also in other healthcare systems, we move more and more to a value-based medicine, where it doesn't matter how many MRs you have read on that day. for your income or for the hospital's income, but it matters how efficiently you were able to diagnose and treat patients. What that means is hospitals will more and more get paid for cases, and the faster and the more accurate they can solve a problem and treat it, the better it will be. So I could do an echo and could do a nuclear scan and a stress test and then figure that out, or I could do an MR scan. If the MR scan can be done on the same day, I have all the answers I know, I can discharge the patient or treat on the same day, that saves a lot of money, even though the technique may be in some countries more expensive than say a nuclear scan. So where I work in Canada and my experience in Germany, MR is still cheaper than a nuclear scan. But the move to value-based medicine, I think, will play a huge role in the future, which means when we go from service to fee for outcome, a technique that has a clear impact on outcome is important. Now, the challenges for MR are manifold, and will not take the time to go through all of them. They're weighted here in terms of the font size. I think the most significant problems are politics, tradition, reimbursement, and the length of the scan and cost. And while we'll certainly not address the politics, I'm happy to invite everybody of you to discuss with me that one-on-one. This length of the scan and the costs are important. Now, if we just do, and excuse me if these numbers are not correct for your side, it's just a ballpark. If you take the baseline cost of a scanner and add the cost for the staff, then you know there are costs associated with the technology that every minute counts that you can spare. And of course, in a scanner that is busy with knees and heads that may take 15 minutes, then it doesn't make a lot of economical sense to do a cardiac MR for 45 minutes. So that is why it's important. Now let's look at what we do with MRs. So this is from one of the publications, but others have actually came to similar results. We know that about a third of the indications in most centers is coronary artery disease, a third is cardiomyopathy, and if you add the viability actually to coronary artery disease, in some centers it's now 50%. But that means in about 80% of the cases, what we really want to know from an MR scan is very simple: function and tissue characteristics. And tissue characteristics, especially edema, is it acute or not? Is it irreversible? And in some patients, is there a perfusion deficit? So that alone in coronary artery disease is good for 34% of the indications in this example. If you have a non-ischemic cardiomyopathy, you just remove the perfusion, and that's good for another 47%. So that means in 80% of the cases, a fairly simple protocol just looking at function tissue would be sufficient. Now, for perfusion, this may look like this. This is from a paper we published as a consensus group a couple of years ago. You can do a perfusion scan with function, perfusion, and late enhancement in 20 minutes. If you really need the rest perfusion, you can add another few minutes. But this is already an example that is applied, and I know a lot of centers that do that on a daily basis. They do their 10, 15 scans a day, and it runs smoothly. If we just look at what I showed before, what you can do now with an efficient technologist and state-of-the-art scanning, and we do that, for example, using the 1.5 Tesla ARTIS we have, is for coronary artery disease, use a cine sequence, and you use tissue characterization based on T2-weighted imaging and or maps. Then you can run these protocols in 25 to 30 minutes. So this is what we already can do. And this is an example just from a recent, sorry, the movies don't loop, I'm sorry, that is to the upload. So this was initially thought to be from the echo non-ischemic, or was called dilated cardiomyopathy, was sent without further ado to us. And yes, there's basically a global wall motion abnormality, but you can also see, and I'll run through that again, But you can also see that some areas, although the wall thickness is pretty much the same everywhere, it's pretty thick, but some areas perform less, so the infralateral wall here was significantly worse. So just looking at that alone would already state, okay, that could be non-ischemic, but could also be ischemic. So looking at the T2 map, here shows that some areas, in this case the infralateral wall, is different, and of course you can do this as a map and get these numbers straight as a quantitative measure and not so much as just the signal intensity to look at. So just in this case took just 20 minutes and we had all we needed to know. We knew this is ischemic cardiomyopathy, and with an infarct, and here you see the late enhancement images, we may not even have needed the contrast agent here because it was already pretty obvious from the T2 and the T1 maps. But this is an example where a short protocol gives you the answers. So this patient then went to the cath lab and eventually ended up with a multi-vessel PCI. So here's a short axis view. So yes, there are techniques out there that allow us to do this faster than we used to. Compressed sensing, for example, allows, and this is work from Mannheim, to have a single breath hold for the short axis stack. So these techniques are out there. I think I would expect even more from the future, not so much from compressed sensing, but from machine learning, that we will be able to use sparse data set to speed up this quite significantly. And where this, a good example where that matters is the TikTok trial. This is just one of the trials of the vast outreach program we are seeing in South America and India and elsewhere, and a couple of companies helped to support that, and the SCMR is active in that, where in this case they scanned more than 100 patients basically on a weekend, including function and T2 star, which was an important diagnostic marker, and the mean scan protocol was 8 minutes. So with that, even in a country that has to count every minute, that is a cost-efficient method, because in all these patients you could make informed decisions and improve their outcome without anything else than just a working MR scan, and no contrast agent involved here. So mapping is one of the techniques that are a bit, let's say, not as long as around as others, and we know that that mapping can be used to identify some diseases fairly specifically. That's amyloidosis, iron overload, myocarditis, and Fabry's disease, and others you can get very strong diagnostic information. So, for example, Fabry's disease, I would feel comfortable making such a decision without the use of contrast agents, to have in a very short protocol, and if you heard probably here about fingerprinting, that could be in the future something, within a few minutes get the information you need to provide solid diagnostic information. And this is how it looks like in a non-ischemic cardiomyopathy. So a short protocol, again, Cine, T1 map, T2 map would be sufficient for many. If you need iron overload to rule that out or rule that in, then T2 star mapping may be added. So these are examples. So the one I showed before in the patient with the infarct, with the previous infarct, with the cardiomyopathy. And here, these are, this is the recommendation for non-ischemic cardiomyopathy. Now, just to provide a brief glance of how this could be even more facilitated in the future. So now it takes about 20-25 minutes. In the future, beyond compressed sensing, a technique like fingerprinting may play a big role. Fingerprinting, and I will not take too much time to go into more detail, in a nutshell means that instead of thinking beforehand whether I want to have a T1 map or a T2 map, I use basically a pseudo-randomly assigned high-frequency pulses and use a dictionary, so patterns I know and can recognize, to identify the tissue retrospectively from basically a map of noise, if you want. So you get non-selected MR signals and then use machine learning-based algorithms to identify the underlying tissue pathology. And with that, you can actually shorten that. And so in the future, it may be possible to do this in 20 minutes if you want to use perfusion, or in non-ischemic disease, maybe even in 10 minutes. And that is, of course, a totally different ball game. Another factor, and this is just because I'm myself very enthusiastic about that, so take this with a grain of salt and bias here. As another example how this may be changed in the future, we have, since years, we have validated and now are applying this breathing maneuvers instead of adenosine as a vasoactive maneuver. Believe it or not, as you sit here, if you hyperventilate for a minute, your blood supply to the heart and the brain will decrease. You will feel maybe even a bit dizzy or panicky. And if you hold your breath, it's the opposite. Your blood supply increases. And you can actually demonstrate and track that with oxygenation-sensitive MR. That's what we did, and this is actually work from Switzerland, a recent study showing that this technique will allow for identifying coronary artery stenosis. Think about it, that's 1 minute of hyperventilation, you start scanning for 30 seconds and you have your data. No contrast agent, no pharmaceutical agents, a needle-free technology that uses advanced tissue characterization. So this would be another way to increase, so if you take, and another one is multitasking, and if you take that all together, multitasking, as I said before, it may allow you to generate a 3D data set. They still need about 20, 30 minutes, but let's say in the future 15 minutes, and then you have all the images calculated. Now, of course, a problem with that is if you generate 400 or 500 images in 10 minutes and do that 20 times a day on your scanner, that's a lot of data, so you need to deal with that. So we will need to catch up in the future with software that allows to digest all that and basically present that in an understandable fashion. So let me summarize short protocols that include just function and tissue parameters. They work already as we speak and sit here for coronary artery disease, including perfusion, and cardiomyopathies and myocarditis. Of course, they don't work for congenital heart disease. Of course, they don't work for complex valvular disease, for masses and all that. But 80% of the indications are just the bread and butter. And I recommend it in my past often to people when they get started in CMR, say, forget about all that. Just offer your doctors a viability scan to start with. And just do cine and late enhancement, that's it for now. Now with the mapping technology being more and more robust, that could be easily expanded. If you have a good mapping solution, and you know the normal values of your scanners, and you have a tool that provides you the maps, then just add that. That's already possible right now, and then you can expand from there. And similar for the other big portion of our indications, cardiomyopathies, that includes myocarditis. And we have just published a few weeks ago the updated Lake-Lewis criteria. And one combination of criteria that can be used according to these is just T1 and T2 map, period. And if you add the cine, then you have information on morphology, function, and the pericardium. So you have all it needs to provide significant diagnostic information for your workup. So in the future protocols, that may look even much better. So it's a great time to get started. That may be free breathing, non-contrast. That may, however, also be using a simple breathing maneuver. And in the future, this will be essential, but it also will, for us, as we're here, we're all proponents of CMR, I think will be the important breakthrough to get across that hump being compared with techniques like nuclear, which clearly is so limited that it's almost embarrassing talking about that. Sorry if there are any nuclear cardiologists here. Happy to have a discussion. And I would just recommend, please move over, get an MR scanner, and add that to your armamentarium. You will be happy with that. But in the future, it will be essential in a value-based medicine that is not only compatible with a healthcare system that is sustainable, but also improves outcome. Thank you very much.